Excuse me. Hello. Bismillahirrahmanirrahim. Another lecture on gastrointestinal bleeding. Very, very important topic because whether you got either OPD or emergency, you will come across a patient with gastrointestinal bleeding, either upper GI bleeding or lower GI bleeding. The lower GI bleeding will come in the OPDs, less emergency, but upper GI bleeding most of the time, our factors, they will come in emergencies, especially the medical emergencies. So you must know what are the objectives of this topic, what is upper GI bleeding, what is the lower GI bleeding, what is the demarcation point of this upper and lower GI bleeding, what are the investigations for these upper GI and lower GI bleeding, and how to manage the cases of GI bleeding. So, two types of bleeding. One is upper GI bleeding and lower GI bleeding. So, how to know what is upper GI bleeding and lower GI bleeding? There is a demarcation point, and this point is called as ligament of Pearce. Over here is a point. This is a peritoneal condensation that is called as ligament of Pearce. And bleeding can come anywhere from the pharynx, esophagus, stomach, duodenum, jejunum, ileum, large intestine up to the rectum and anus. So, but this point, this is called as over here. There is a peritoneal condensation. This is called as ligament of Pearce. Above this level, there is upper GI bleeding. That is anatomical, not physiological. And below this level, there is really low GI bleeding. At this point, it is also called as duodenojejunal flexure, DJ. DJ junction or duodenojejunal flexure. So above this point is upper GI bleeding. Below this point is lower GI bleeding. Upper GI bleeding usually presents with hematemesis, that is vomiting of blood, and melena, isn't it? So, lower GI bleeding usually presents with hematopoiesia. Why this upper GI bleeding presents with melena?
So they just
Oxidized.
Oxidized because it takes time. Blood coming from upstairs, it takes time from blood in this region to come down. During this process, there is degradation by the bacteria. So color is changed from reddish to usually blackish in color, isn't it? And in hematopoiesia, bleeding is coming lower down, less time to come to the exterior, so there is less time for degradation by the bacteria, so color is usually maroonish or reddish in color. That is hematopoiesia.
بس منين يجي أصفر لكن تاري.
What is the basic management? Before I go to different types of GI bleeding, what should be the management of GI bleeding?
Stabilize the patient.
Yes, these have three components. One is you will have to resuscitate and initially assess the patient. Resuscitation means you will have to optimize the patient by giving IV fluid. While patient has come to you, he may be having this, he may be in the shock, blood pressure is down, he's having tachycardia, he is devoid of his blood, so you will have to resuscitate the patient and assess the condition of the patient. Then localize the site of bleeding. From which side this patient is bleeding, you will have to localize. And for localization, there are different measures, and I will tell you. For lower GI bleeding, there is proctoscopy, anoscopy, sigmoidoscopy, colonoscopy. There are different methods. Then of course there are angiography, where you can do this localization of bleeding points. And in upper GI bleeding, you have this gastrointestinal scope to localize the lesion. So these are the localization tools. Then the therapeutic intervention to stop the bleeding. What are the measures to stop this bleeding? So Then we will discuss one by one what are the different causes of bleeding. Before I go with causes, diagnosis, and treatment of lower gastrointestinal bleeding. These are these causes are vascular anomalies, macroverticulum, diverticulitis, ulcerative colitis, Crohn's disease, tumors of the small intestine, tumors of the large intestine. Next. Hemorrhoids and fissures, fat, pseudomembranous colitis. Next. So we will discuss one by one. One cause is vascular anomalies or angiodysplasias. What are these angiodysplasias? These may be called as pupillary or venous cholangiomas. These are the distorted blood vessels, mainly in the right side of the colon, and most of the time this is ascending colon and the cecum. Reddish raised lesions on, when you see on endoscopy, and these lesions are usually present in the elderly patients. Age is more than 60, and patients are usually Europeans. You don't see these kind of patients with this vascular anomalies or angiodysplasia in the Asian population. These are more common in the Europeans. So whenever you come across with bleeding, age is more than 60 or 70, you must consider something else, that is tumors. So angiodysplasia in our Asian population is very, very rare. These are few millimeter in size, reddish raised areas, and the endoscopy and on histology made of dilated, distorted, thin wall vessels that will bleed. If they are engorged, they are distorted, they usually bleed, and when they bleed like hell. It is profuse bleeding, and patient may go into shock. Next. Sometimes associated with aortic stenosis. At that time, it's called as Hedy syndrome. H-E-D-Y-S, Hedy syndrome. So, what to do with these angiodysplasias? There are different methods to localize. One is, of course, not helpful, that is barium enema, because when you do this barium enema, there is no result, because there is no outpoaching in this area, so it should be avoided. Other test is radioactive test, that is technetium-99 scan. It's a good test to localize that area, which area is bleeding, but usually this test is only diagnostic. So we can do this angiography as well. By doing this angiography, you can localize the area, you can carterize that area. So that is the advantage of this angiography, either superior or inferior mesenteric angiography. Just like you do angiography in the heart as well. So you do this angiography, there is a blush in that area, you can carterize that area. So if you are even not successful by this angiography, what to do is you can do this colonoscopy. In the colonoscopy, you can pinpoint that area, you can carterize that area, but sometimes this bleeding is so heavy, even by doing this colonoscopy, you cannot carterize that area. So what to do then? You will have to open that one. That is the open surgery. And even you will have to do the colectomy for this patient. You have to remove all the colon, because you cannot pinpoint that this area is bleeding. So what to do? You will have to do all removal of the colon. That is colectomy. Next. Then is Meckel's diverticulum. I hope you all know about this Meckel's diverticulum. This is the outpoaching in the distal part of the ileum, and there is a 2% rule, that is present in the 2% population, 2 feet from the iliacal junction, 2 inches long, and there is a usually maroon colored bleeding. Patient present with bleeding. And this Meckel's diverticulum usually present in the younger age group, less likely in the older age group. So whenever it present, it can present with bleeding. So how to localize this? There is a scan which is called as technetium-99 scan. This is the diagnostic measure of the choice for this Maccus diverticulum, and treatment is Maccus diverticulectomy. Just like you remove this appendix, you can remove this Maccus as well. Sometimes Maccus are present in a younger age group, so sometimes patient present with abdominal pain, and we suspect that this is appendicitis. Signs symptoms are similar to appendicitis. You open the abdomen in suspicion there is appendicitis, and you see the appendix is normal. So what to do is, then you will have to look for the Maccus as well. Just go towards the ileum, the distal ileum, and see is there any Maccus diverticulum. Then you see that Maccus is basically involved. That is not the appendix. This is the Maccus, and this is called as Maccus diverticulitis. Then you do Maccus diverticulum. So one presentation of Maccus diverticulum is bleeding, other is pain, just like a pain of appendicitis.
The only way to know that's
Only because if it is not bleeding, you don't do this technetium 99 scan. You just think this is appendicitis, isn't it? But when you examine on laparotomy or this after this incision, you see this appendix is totally normal. So you will have to see Maccus, and then you see, oh, this Maccus is involved. Then is diverticulitis. And what is diverticulitis? This is a complication of diverticular disease. I hope you all know what is diverticular disease. Diverticular disease is presence of multiple diverticula in the colon. And mainly these are the diverticula on the left side of the colon, that is sigmoid colon. And patient can present with acute bleeding, patient can present with perforation, patient can present with abscess formation in the diverticula, and whenever there is a hemorrhage, this is a profuse chronic hemorrhage, and in 70% of cases, blood transfusion is needed. And what is the diagnostic measures? Barium enema, sigmoidoscopy, and colonoscopy. Barium enema, I told you before, there is a sawtooth appearance, isn't it?
okay.
Sawtooth appearance, just like tooth of a saw. You know what is saw?
Sharp.
Sound appearance?
Sawtooth appearance. Sawtooth.
Doctor, the barium enema we don't do if there's a case of diverticulitis.
Sorry?
The barium enema we don't do in the case of
In
diverticulitis.
case of uncomplicated,
Uncomplicated.
when I say there is no abscess
Because it
formation,
might perforate.
might perforate. There is no abscess formation, there is no, perforation, but in case of mild to moderate bleeding, you can do. And treatment is resection and anastomosis. You'll have to remove that part of the colon, and then you have to make the anastomosis. Next. Ulcerative colitis and this Crohn's disease are collectively called as inflammatory bowel diseases. Etiology is different to chronic disease, but whatever its etiology, usually say, sometimes say it's a bacteriological disease, but sometimes say this is environmental disease, but still there is a no one point and what is the cause of this disease, but whatever it is, it's a chronic inflammatory disease, and most of the time this ulcerative colitis present with bloody diarrhea, isn't it? 4 stools, 5 stools per day, 6 stools, 10 stools, depends. This is the severity of the disease. Either it's a moderate disease, either it's a mild disease, or it's a severe disease. Whenever it's present with diarrhea and present with severe rectal bleeding. And it requires transfusions. And what are its complications? I hope you all know what are the complications of ulcerative colitis. Sorry? Complications.
Toxic colon.
Toxic megacolon, yes.
Pancreatitis.
Sorry?
Pancreatitis.
Pancreatitis,
Cancer.
cancer formation. What else? Extraintestinal manifestations. What are the extraintestinal?
Sclerosing
manifestations?
meningitis.
Sorry?
Sclerosing meningitis.
Sclerosing meningitis, yes. Iritis, eye signs, uveitis,
Spondylitis.
erythema nodosum. What else?
Ankylosing spondylitis.
Sclerosing meningitis, cholestatic jaundice. These are the extraintestinal manifestations of this disease, and it presents with the bleeding as well. So my topic is on the bleeding. So I think you all know what are the differences of this ulcerative colitis and the Crohn's disease, isn't it? What are the differences of ulcerative colitis and the Crohn's disease?
Crohn's is
intramural.
First is the site.
left lower quadrant.
Crohn's can be
From the mouth to the anus, but this ulcerative colitis is
mainly colorectal.
it starts from the rectum. If it doesn't start from the rectum, it's less likely that it's the ulcerative colitis. Most of the time, it starts from the more than 90% cases. It starts from the rectum, goes backward in the colon, then to the ileum, when it's called as backwash ileitis. What are the other differences?
Intramural lesion.
Continuous like Crohn's. Ulcerative colitis, continuous.
These are the continuous lesions. Continuous lesions.
While Crohn's disease.
But Crohn's disease has skip lesion. One area is involved, then
Normal area.
normal area, other area, normal area, other area, like this. So these are the features of Crohn's disease. And what else?
Crohn's is transmural.
It's a transmural.
And just because of some mucus.
Yes, this is a transmural. That's why in Crohn's disease there are
Stricture.
strictures and fistula formations. And of course, there is a perianal disease in the ulcerative colitis is more than this ulcerative colitis. Perianal disease, that is fistulas, abscesses, these are more common in Crohn's disease. Why? Because it penetrates to the other areas. Not my point. So you must know about these features. The treatment is, one is medical treatment. Give anti-inflammatory drug like Asacol, 5-amino salicylic acids, Asacol. But, and of course, you can give steroids to start with. To start with, this ulcerative colitis and Crohn's disease is a medical disease. Patient usually go to the physician. But if there are complications like this toxic megacolon, the bleeding, like this, whenever there is an extraintestinal manifestation, then there are indications for the surgery as well. And one to two of the surgery, treatment for severe fulminating disease or really for severe hemorrhage or colectomy. You will have to do what? Colectomy. You will have to remove all the colon which is involved. Got my point? This is the treatment for ulcerative colitis. Start with, this is medical treatment, steroids, but if there is a perforation, bleeding which is uncontrollable, you have to give a lot of blood, then what to do is, you have to give surgery. Yes? Crohn's disease, just like ulcerative colitis, as I told you, start from the mouth to the anus, transmural disease. But most of the time, it presents with stricture formation, less likely with bloody diarrhea, but it may present with bleeding. But most of the time, there is a pain abdomen, there is a stricture formation, there are intestinal obstruction because of these Crohn's disease. Treatment is similar to this ulcerative colitis. And what is the treatment? Medical treatment, just like Asacols, and of course surgical treatment. But the difference between treatment is that treatment of Crohn's disease is limited. You will have to do limited sections, not like ulcerative colitis. In ulcerative colitis, you remove the whole colon and patient is disease free. But because in Crohn's disease there are skip lesions, one here, one here, one here. So So what to do is you'll have to do limited section. Section anastomosis. The section anastomosis to spare the remaining gut. If you remove all the colon or the small intestine, patient will be in problem. So you cannot do this. Advanced surgery in Crohn's disease. You'll have to spare the different.
No.
Gut. Yes, next. Tumors of the intestine. Patient may present with bleeding in tumors of the small intestine, like lymphomas, like carcinomas, like carcinoid tumors. Tumors of the large intestine, that is adenocarcinoma of the colon, carcinoma of the rectum. Frankly speaking, tumors of the small intestines are very, very rare. In my practice, I have not seen a single case of tumors of the small intestine. And whenever we have seen a patient with rectal bleeding, colonic bleeding, and most of the time, these are the tumors of large intestine. So you can expect that more than 90% of the cases of tumors are large intestine, less likely the small intestine. So whenever you are coming across a patient with tumor intestine, you must be confident that you are dealing with a tumor of most probably the large intestine tumor. Now of these large intestinal tumors, 65% of tumors are on the left side. When I say left side, it means rectum and descending colon. And 35% of the tumors are on the right side, that is cecum and the ascending colon. And these tumors present with what? Bleeding, obstruction, and anemia. And these are the left-sided tumors which usually present with bleeding and obstruction. And most of the time, these are the right-sided tumors which present with the mass and anemia. Like cecal tumor usually present with the mass formation and anemia. There is very little bleeding. But if there is a tumor in the left side, that is the rectal tumor, and the descending colon tumor will present with mass inside and obstruction and bleeding. This is usually the rule in. So what to do with these tumors? Diagnosis by barium anemia. You can do barium, and there is a filling defect in the barium. Sigmoidoscopy, colonoscopy. You can visualize a tumor. You can take biopsy. Then what to do next?
Section.
Section.
Yeah.
You want
After
don't
biopsy.
want to do further test or
After biopsy.
after biopsy? Of
Yeah.
course.
Compare which type.
After biopsy, tumor is adenocarcinoma. Adenocarcinoma is the commonest tumor in the bowel. Not my body. It's adenocarcinoma. I mean. So on biopsy, it shows this is an adenocarcinoma of colon or rectum. So what to do next? Section rectally.
Check the metastasis.
So what to do for the metastasis?
Chest X-ray. and,
X-ray.
X-ray.
Abdominal X-ray,
Pelvic.
pelvic X-ray.
Yeah.
So X-ray will tell you the metastasis. How
PET
to
scan.
scan? You will have to do the scan because whenever you have taken the biopsy, it gives you an idea this is adenocarcinoma. Next point is you will have to do what? You will have to stage the tumor. Without staging, you cannot go further. You will have to stage the tumor. Is this tumor has gone to the liver? Is this tumor has gone to the chest? Then you plan for the surgery. Next plan is you will have to resect the tumor. Next. Other causes of GI bleeding, rare causes that are
So,
fat.
doctor, we detect other metastases through CT scan or which scan?
CT
CT.
CT you can do MRI, no problem. You can do CT scan, you can do this MRI.
What about PET scan?
Scan, you don't do this, the thing, when you do this CT scan and you have diagnosed that this is the diagnosis and everything is clear, why to do this positron emission tomography? You will have to see the facilities in your hospital. Sometimes MRI is not available. Sometimes CT is available. MRI is expensive than the CT scan, but for the soft tissues, MRI is better than CT scan. I told you before. MRI is better than CT scan. So what is FAP? This is familial adenomatous polyposis coli. So how to differentiate? This is a FAP patient. What is the diagnostic criteria of FAP?
Hundreds and thousands of polyps.
If more than 100 polyps you can see in colonoscopy, this means this is a FAP. So what is the treatment for FAP? Patient present with bloody
Section.
diarrhea, bleeding. Sorry,
Section.
you will have to
To do total collective.
total colectomy. You will have to remove the polyp. And hemorrhoid. Anybody who can tell me what is hemorrhoid?
Gorged veins, the air canal.
These are dilated tortuous vein in the lower part of the anal canal that bleeds. And there are different degrees of these hemorrhoids. That is a grade 1, grade 2, grade 3, grade 4. In grade 1, there is only history of bleeding. Nothing comes out of the anus. In the second degree, there is history of bleeding. Something comes out of the anus, that is hemorrhoid, but it spontaneously go upward. In the third degree, there is history of bleeding. Something come out of the anus.
You have to manually push it.
You will have to manually push this up. In the fourth degree,
It's not
it's not
every-
possible to push it inside. This is the fourth degree. Now there are different treatments for these hemorrhoids. One treatment is lifestyle modification. You will have to give a lot of fluids, salads like this. Yes, high fiber diet. Okay. Then other treatments are you can give this injection sclerotherapy. The area which is bleeding, you can give some sclerosing agent to that bleeding area. It will be finished. Other is you can do what? You can ligate that stump of these bleeding vessels. The next thing is the surgery. That is hemorrhoidectomy. There are different types of hemorrhoidectomy. Open hemorrhoidectomy, closed hemorrhoidectomy, then stapler. You can use a stapler to ligate these vessels. That is stapled hemorrhoidectomy. So, other cause of bleeding is anal fissure. What is anal fissure?
Tear.
It's a tear in the
Wall.
where?
Stereo.
Side, the mucosa.
In the mucosa, in the lower part of the anal canal, most of the time it's on the 6 o'clock position. Most of the time it's 6 o'clock position, and there is, and these fissures are usually painful. Why painful? But because these fissures are on somatic area, that is squamous epithelium. There is a dentate line. Above the dentate line, there is columnar epithelium. Below, there is somatic, that is squamous epithelium. So whatever on the somatic epithelium, that will be painful. So this fissure is on lower anal class. That's why and the patient gives you the history that he is having constipation, hard fecal stool, and whenever he defecates, he feels pain. He feels pain, and there is a streak of blood from that fissure to the fecal matter. You can see on the toilet paper that there is a fecal matter and there is a streak of blood. That gives you an idea this patient is having what? Anal fissure. So you must have to differentiate between, because every day we come across a patient with bleeding per rectum, and we will have to differentiate between hemorrhoid and anal fissure. In hemorrhoid, which are uncomplicated, there is usually no pain, because internal hemorrhoid comes from columnar epithelium. Not my point. So there is no pain, there is a painless bleeding. But in case of anal fissure, there is a painful defecation. And when you examine correctly, as you are doing over here, you cannot push the finger inside the rectum in the case of anal fissure, because sphincters are tied because of pain. Because of pain, sphincters are tied, and you are not going to push your finger because severe pain. But in case of hemorrhoid, you can easily pass the finger. So these are the differentiating points. Few point for the pseudomembranous colitis. Pseudomembranous colitis is a yellowish membrane on the lower part of the rectum or the colon, and this is usually a complication of long-standing use of antibiotics in the surgical ward, in the ICUs. If you are giving cephalosporin, ciprofloxacin, the ICU patient, the surgical patient for a longer period of time, so what will happen? There is a yellowish false membrane and the inflammation in the lower part of the rectum and the colon, and there might be bleeding from that area. This is called as pseudomembranous colitis. And how to treat this patient? You will have to give metronidazole. This is the first line. If this metronidazole is not working, vancomycin. Next drug is vancomycin. And even if it is not working, sorry?
It says I was stop antibiotic and start antibiotic.
Yes. Stop antibiotic and start another antibiotic. Good point. Next. So these were the causes of lower GI bleeding. How to investigate and what is the treatment. Now we come to the upper GI bleeding that present with hematogenesis and melena, and this is major medical point, major medical problem, because most of the upper GI bleeding usually comes with emergency ward. These hemorrhoids and these anesthesia usually come with collectively, little bit pain, little bit bleeding, and you do examination. But this hematogenesis and anemia is a serious disease, and its hospital mortality is 5 to 10%. And this mortality even can increase if patient has some underlying diseases. This mortality can go up to 30% as well. So you will have to see these conditions, a very serious condition. Most common causes are, of course, gastric ulcer, gastric urea, gastric gases. And what to do with these patients, as I told you in lower GI bleeding, investigation choice is flexible endoscopy. You can see everything. And there is usually J-shaped maneuver. J-shaped maneuver, you go in the esophagus, in the stomach, duodenum, and then you go backward like this. J-shaped maneuver is flexible endoscopy. But in endoscopy, the endoscopist must be a senior person, because a new person, he will miss a lot of diagnosis. Must be a senior person. Medical treatment is usually ineffective. Whenever the patient who is bleeding, you give these PPIs, you give these active receptor blockers, you give these injections, usually these will not work. So what to do? You have to do this endoscopy and see the lesions, and you will have to cut right, or you will have to ligate the lesion. So next.
Doctor, what about NGT aspiration?
Sorry?
NGT aspiration for hematomesis.
GT aspiration?
Yes, nasogastric tube aspiration. Is it possible or to do it? Is it better than the endoscope?
Thing is, before endoscopy, you will have to pass nasogastric tube. Why? Because you cannot see, you cannot do endoscopy before if you don't aspirate everything. You will have to aspirate.
So this is the initial step.
Yeah, this is the initial step. This is the initial step. You will have to aspirate. Okay. And sometimes with endoscopy, even you can aspirate. Through endoscopy, you can aspirate, but you can pass, because endoscopy is not always available. Patient comes to you in emergency. So you cannot do this endoscopy at first. So first you have to do something else. That is nasogastric tube. You pass this nasogastric tube and aspirate, give blood, resuscitate like this. Then patient is stable. Go for endoscopy like this. So principles are same: resuscitation, investigation, find the cause of bleeding, and only then definite treatment instituted. And whenever there is a significant GI bleeding, you will have to pass 2 large bore IV cannulas. Whenever the patient is in shock, you will have to pass 2 large bore IV cannula. Why large bore? Because if you give small bore cannulas, fluid cannot be rushed. You will have to give more fluid to the patient and even blood. And if there is severe bleeding, central venous pressure monitoring should be done. You will have to pass these tubes just to measure the pressure inside. You are giving fluid, you are giving blood. It must be checked by these central venous pressure. What is the pressure? This gives you the idea that your resuscitation is good or not. Not by IV line. Central venous line. Central venous line will give you idea that your resuscitation is good. And of course, you will pass this nasogastric tube. Bladder catheterization should also be done. Why? You are giving a lot of things and you don't measure this union output, patient will be in trouble. Next. So, blood transfusion should be given, patient transfused, suspension, like this. Whenever there are known esophageal varices, now the patient has come with esophageal varices, what to do?
Give them beta blocker.
Sorry?
Beta blocker to the patient.
Sorry?
Give the patient beta blocker.
Beta blocker and beta blocker as well.
And do the balloon procedure.
What is that balloon procedure? That's what I'm asking. This is Sanax-taken Blackmore tube. What is this tube? This tube is just like you pass nasogastric tube. This tube has, if the patient is presenting with this esophageal varices, this tube has 2 balloons. One is gastric balloon, other is esophageal balloon. And patient is bleeding like a hell. In that case, endoscopy is not possible. So what to do? You pass this tube inside and you inflate the balloon. One balloon in the stomach, one balloon in the esophagus. So what will happen? When it will be inflated like this, bleeding will be stopped. Bleeding will be stopped for the time being. Now this is the time to resuscitate the patient.
This is temporary, right?
This is temporary. This is temporary, not for all. Because if you push pass this tube for there will be ischemia. If you pass this for 2 days or 4 days, there will be ischemia. So this is for the time being. When the bleeding is controlled, then you go for the endoscopy. And on endoscopy, you will cut price like this. And sometimes there is a coagulopathy because patients are already having a liver disease. In these cases, you can give this vitamin K. And other thing is FFP, that is freshly frozen plasma. But this vitamin K usually is not affected stately because vitamin K takes 72 hours. Vitamin K effect is 72 hours. So in that period, what to do is you can give this freshly frozen plasma. There are clotting factors in this freshly frozen plasma, so these are effective. Next. So what are the causes of upper GI bleeding? As I told you before, these ulcers are notorious. These are having 60%. So this is a multiple choice question. What is the number 1 cause of upper GI bleeding? That is ulcer. And which ulcer is the number 1? Duodenal ulcer is 33%. And esophageal varices, is only 4%. So whenever a patient presents to you with upper GI bleeding, you must suspect the ulcer first, then other causes. And these are very rare causes. Next, bleeding peptic ulcers. I hope you all know about the ulcers. Isn't it? You know, no? What is ulcer? What is ulcer? Yes, sure. What is ulcer?
It's the one
mucosa or epithelium. Whenever there is a excavation due to inflammation and there is a breach in the mucosa or submucosa, it's ulcer. Isn't it? It's ulcer. So what is peptic ulcer? If there is ulcer below the esophagus to the small, this is peptic ulcer.
No, because of
Why it's peptic ulcer?
due to the bacteria, the bacteria.
Why it's peptic? This is peptic ulcer is basically misnomer. Ulcers in the stomach and duodenum are mostly due to more presence of acid, isn't it? This peptic is related to pepsin. Pepsin. It has a little role in the ulcer formation, but not all. Whenever there is in the stomach, there is mixing of food particles by these pepsinogen and pepsin, and of course the acid. But ulcers are due to more acid, not due to more pepsin. It's a misnomer. It's given name peptic ulcer because of pepsin, but this is a misnomer. Okay, this is because of acid. Posterior ulcer bleeds. In the posterior side, in the duodenum there is a gastrointestinal vessels. So whenever there is a breach in the mucosa, there on posterior side there is a gastrointestinal vessels which are big vessels. So when ulcer penetrate that vessel, there is bleeding. Got my point? Same is the case in the stomach. Posterior side there is splenic vessels. There are big vessels. Breach in the ulcer, bleed like a hell. So posterior ulcer bleed and usually interior ulcer perforate. This is usually a rule. Interior ulcer perforate, posterior ulcer bleed. Got my point? And number one cause of ulcer is usually sorry?
And say it.
NSAIDs, and NSAID is number 7.
Aspirin.
Usually this is H. pylori. H. pylori is notorious for having these ulcers. Other one is NSAIDs. So whenever you have to give NSAID to your patient for some pain like this, you must
Give them
do this.
antibiotics.
Sorry?
Give them antibiotics, right?
Antibiotic?
Yeah.
Why?
For the bacteria.
No, that is another thing. That is eradication.
As prophylactic.
If the patient is having ulcer, then you will give antibiotic.
Yeah.
I'm talking about if somebody is taking NSAIDs and he's not having ulcer, patient is taking NSAID for some pain in joint and muscle like this, must give some sugar-coated NSAIDs. There must be some protection because these NSAIDs damage the mucosa. Sorry? There must be some coating of these NSAIDs because these NSAIDs do what? They destroy the mucosa. And they are anti-prostaglandins. Isn't it? This prostaglandin is make the covering of mucosa, mucous membranes. So these very, very important. So whenever you have to give this NSAID, you will have to give this covering. Okay? Next. Medical and minimally intervention treatment for these peptic ulcers. As I told you before, there is a very limited efficacy. All patients who start this NSAID, proton pump inhibitor, opioids, but usually it's not effective. Then what you will have to do, you can do this laser ablation. You can give this injection to that bleeding vessels. That is the adrenaline injection. Because this adrenaline is vasoconstrictor. So when you pass this injection to that bleeding area, there is like this. But when this treatment is not effective, then you will have to do what? You will have to go for the surgery. So what is the criteria for surgery? When there is continuous bleeding, on endoscopy you are doing endoscopy and you see there is continuous bleeding, significantly visible vessel in the ulcer base, spurting vessel in the ulcer, clot in the ulcer base, and elderly unfit patient that require more than 6 units of blood. If you have given more than 6 units of blood, it means you will have to do something extra. That is a surgery. Next. So, what should be the surgical treatment? As I told you before, the duodenum is the most common area involved. So, what to do in surgery? You will have to do open. You will have to do laparotomy. And in laparotomy, you open up the abdomen, you mobilize the duodenum, you make incision that is longitudinally on the duodenum, and you see on the posterior wall there is a bleeding vessel. And what you do is you underrun that vessel, you ligate that vessel. After ligation, you close the duodenum transversely. Why transversely? You open it longitudinally, so you want to close it transversely, because if you close this longitudinally, there will be stricture formation. Then you will have to do this transverse. This is the surgical. Next.
This is the last step, right? The surgical.
Surgery is the last step. Surgery. This is not the first step. You will have to control this bleeding with minimally invasive procedure like endoscopy, bleeding vessel cauterized, not able ligate, injections like this. But indication is spurting vessel, you cannot control endoscopically, all the measures have been failed. You will have to save the life of patient. Patient is bleeding, whole blood is going out. So you will have to do surgery. Next. Few things about causes of bleeding, that is stress ulceration. What is stress ulceration?
Also due to
Stress. Mental stress? Stress ulceration is whenever there is a major injury, whenever there is a major trauma, sepsis, burns. So what happens is blood supply to the stomach is decreased. Now this is ischemia for the mucosa of the stomach, and because of this ischemia to the mucosa of the stomach, there is breach in that mucosa, ulcer formation. This is a very, very serious disease. Whenever you see a patient in ICUs with MI, with burns, with major trauma, must expect this stress ulceration. Just give them PPIs, some sucral fat, even in the nasogastric tube, just to protect the mucosa. This is the preventive treatment, because treatment is not good. You will have to prevent this stress ulceration. This is very severe disease. Next. Gastric erosion, just like peptic ulcers. NSAIDs are notorious for causing these gastric erosion, and patient will present with bleed, and usually it's also very, very difficult. So you will have to prevent this NSAIDs. The treatment is you will have to deal it endoscopically. Sometimes endoscopically not good, you have to do surgery. Next. Mammary weast tears. And what is this? Longitudinal tear below the gastroesophageal junction due to some repetitive external vomiting. Whenever patient vomit a lot, maybe he's having some alcohol intake, cigarette, whatever. Especially this happens in the European society. They vomit a lot after alcohol intake. There is a breach, there is a longitudinal tear in the gastroesophageal junction. That is mammary weast tear. And treatment is do endoscopy and see where is the lesion, try to cauterize. If not possible, you will have to do this surgery. And what is surgery? You will have to underrun this bleeding vessels. Next. Dilophoid disease is a gastric arterial venous malformation. And whenever it presents with bleeding. These AV malformations are just below the mucosa. So whenever these are not bleeding, you can't see it. You only see it whenever these are bleeding. And what is the treatment? Injection sclerosant. Sometimes identify at the patient, you have to look inside. Sometimes you have to do the gastrectomy. Next. These are, frankly speaking, these things, dilophoid disease, these mammary weast, these are very, very these are only theoretical, but at least you must know. Then is tumors. Just like tumors in the larger intestine, patient may present with tumor in the stomach, and most of tumors are adenocarcinomas, but gastrointestinal stromal tumor can also present with GI bleeding, and you have to treat accordingly. That is, resuscitate the patient, take biopsies, and treatment for this tumor is usually section. That is gastrectomy. You have to remove the bleeding area, and of course, with some normal. Next. Portal hypertension. I think you already have a lecture with this portal hypertension, so I will skip. But at least you must know about these esophageal varices, how they leak, and what to do with the esophageal varices. You start with this propranolol, octreotides, vasopressors, like this. Next. Next. This is the bleeding esophageal varices in gastroscopy. Next. And this is ligation. You can see this is being ligated. This varices is being ligated. It's a rubber band ligation. Next. This is bleeding area. You can see over here. This is being ligated by the rubber band. It's the same mechanism by which you rubber band ligation. Ligate. Same mechanism that you do on you ligate the hemorrhoid in the lower GI. Next. Thank you very much. This was all about this lecture. Any question?
Doctor.